Hey everybody, so excited to be joining tonight. I'll be presenting on conducting a retrospective study. Just the little background, these are some of my publications in JFAS. The majority of them were retrospective studies. Research has become a passion of mine since all the way back since residency. And so I love doing it. I'd love to be able to talk to you guys more about it. So here's kind of the overview we're going over tonight. So initially we're going to talk about how you form an idea and then progress through the steps of through IRB, data mining, statistical analysis, evaluating the results, and then actually writing the manuscript. So the first part is coming up with the idea. The way you want to think about it is what patients are you evaluating? So like what cohort are you going to be evaluating? This could be diabetic patients. This could be patients with Charcot. This could be patients with flat foot. So you're really just thinking of like what is your cohort and how you're defining it. And the second part is what are you comparing within that group? So if you're comparing patients with Charcot, for instance, and you want to compare patients with and without diabetes or with and without arterial disease. So you want to compare for multiple factors, right? And so when you're comparing for that, you can compare for, so say we're comparing Charcot patients with and without diabetes, you want to compare for multiple factors. So you want to compare for if they have what their pre-op A1C is, if they have renal disease, what their postoperative outcomes are, what their ambulatory status is. So you can compare from multiple factors, and that's where you see what statistical analysis progresses. And then once you have a formulated idea, you want to look in PubMed or other databases to see if something's already been published in this field. So here's an example. So if we have a cohort of patients with Charcot that underwent surgery, and you're comparing them for with and without diabetes, and then the factors you can compare for, this is really whatever you want, whatever you have data mined. So you can look at age, BMI, hypertension, PAD, renal disease. You can compare for any number of these things, or postoperative outcomes, delayed union, dehiscence, amputation, recurrence. And so this is an example I'm going to progress throughout the presentation so you can have an understanding of how to think about a research paper all through this lens. So overall, we're looking at patients with Charcot, and we're comparing patients with and without diabetes, and then we're comparing them for multiple preoperative and postoperative factors. So there's a presentation already performed by the ACFAS Research Committee on IRB processes and ethics. And so you can use that. That was the October meeting. Most institutions have IRBs that are pre-filled out templates. And so you just get the pre-filled out templates and fill in the information. I'm not going to go into great detail on this because there's already a full lecture on it. And every institution is slightly different. So let's go right into data mining. So the way to think about data mining is you want to think about in terms of how you're going to find your patients and how you're going to evaluate them. So once you have that defined cohort, you can get the list of patients either through ICD-10s or CPT codes. So ICD-10s are great if you are looking for patients with a specific diagnosis. So, when Adam's a physician in a year or so, he can search for patients that had all of his patients that he had flat foot, right? So you can search for PPTD. And so the way you would do that is you look up the ICD-10 codes for PTDD. You just want to include left and rights. So this is one way to find your patient cohort. The other way is through CPT codes. So CPT codes are surgical billing or your actual billing. So rather than looking at by diagnosis, you're looking at what was done on the patient. So if you want to determine if it was a single surgeon, multiple surgeon within what you're searching for. So for example, if you want to look up Dr. Bradley Lamb's patients who underwent multiplanar external fixator device, you would send it over to there's different departments within the hospital or your system that can pull these patients for you. And you have them look for Dr. Bradley Lamb's patients with the CPT code 20692. And that's just the example of this specific code. So you'd look it up for whatever surgical code or diagnosis you're evaluating. And then you get a list of all the patients. And then once you get this long list of patients, you want to define what patients you're keeping in this data set to look up and which ones you're excluding. And this is really what comes down to your inclusion and exclusion criteria. So the inclusion criteria, you wanted to define your cohort, right? So if you're looking for patients with Charcot, you want to define a cohort as patients with Charcot. And you have to have a clear definition of how you're going to distinguish between the patients with that. And then if you want to also have inclusion criteria, like our paper we were talking before, patients that underwent surgery, or patients that had this procedure performed. And then you want to define your exclusion criteria. So you want to evaluate if they're under 18 and if you don't want to include pediatric patients. So part of the exclusion criteria is going to be age or less than 1 year follow-up. These are some examples. Every study is different. These are just some highlighted ones. So following that previous example we were talking about of patients with Charcot, with and without diabetes, our cohort is patients with Charcot, but you have to define that, right? And so it's defined as joint subluxation, dislocations, presence of small osseous fragments. So, these are a lot of radiographic definitions. So for this cohort, you'd have to be able to evaluate the radiographs preoperatively to see if they fit your inclusion criteria. Further, you want to evaluate if these patients underwent surgery, right? So our cohort at the beginning was Charcot patients that underwent surgery. So you have to make sure you define both the Charcot patients and the surgical factor, right? And so you could have a list of the ICD-10 codes for Charcot and a list of the CPT codes for the Charcot procedures, and you can match the MRNs to make sure that you're only including the patients that have both of those. And then once you have that list whittled down, you can exclude patients based on their age or follow-up or whatever the other exclusion criteria you have are. And then when you're evaluating for the factors, right? So that was really defining our cohort and what we're comparing. And so once we're defining the factors we're comparing them for, you can't just compare by age. You have to define it more clearly. So you want to have age at time of surgery or peripheral arterial disease. How are you defining peripheral arterial disease? Is it by angio? Is it by Doppler pulses? Is it by pedal pulse palpation? So you have to define specifically how within your cohort you're defining them. Renal disease. So is that including CKD and ESRD? So you have to define that one within your study. And then this is going to help you determine how you're data mining all these patients, right? So ahead of time, you have to have a map of how you're thinking about each of these things you're data mining. And if you're data mining for amputation, how are you defining that? So are you distinguishing between minor amputation and major amputation? Are you distinguishing between below the knee amputation or above the knee amputation? Typically, I put all minor amputations together and all major amputations together, depending on the type of study I'm performing. But if you're evaluating level of amputation, you probably want to specifically break up minor amputation by each category. So you have to think about what works for your study and how you're defining each thing you're evaluating. And then for post-op ambulation, how are you defining that? So you want to define it as possibly non-ambulatory, partially ambulatory, fully ambulatory, and you can break this down into further categories. So you have to figure out the best way you're going to define each of these, and then that's how you're going to data mine it. And then a way to think about these factors is there's continuous variables and categorical variables. So continuous variables, I like to think of as they're on a spectrum. They just keep going, right? So we have age. We know it progresses. BMI, the same. A1C. They're not binary or defined numeric values. Whereas categorical variables typically are either yes or no's or like 1, 2, 3s. You can answer them. And so, for example, do they have diabetes? Yes or no. Are they post-op? What is their post-op ambulatory status? You can define it as 0, 1, 2, 3. And so once you have that mapped out and you know how you're defining each of these, you want to make a clear, concise message for each of these. So let's zoom in on this. So once you have the age of time of repair, the way I typically do this is you have the date of surgery, if you are searching by the CPT code, and you have their date of birth, usually already provided. And so I just make an equation and I subtract the date of surgery minus the date of birth, and that gives you age of time of repair. Diabetes, you typically have to look in the chart for. And then, BMI, whereas diabetes, you can look if there's a diagnosis. CKD, if you're defining it as both, renal disease as both CKD and ESRD, you can data mine them separately or together. And you want to answer yes or no's throughout the data mining. And then for preoperative ulcer, you're saying, is it present? And then if it's where the location is, so rather than saying pre-op location and typing in, so pre-op ulcer and typing in forefoot, midfoot, hindfoot, have everything in 0s and 1s because this will allow your statistician to work more fluidly. So for example, is pre-op also there? Yes or no? Is it in the forefoot? Yes or no? Is it in the midfoot? Yes or no? Rather than saying location and typing in forefoot, midfoot, she'll end up having to change all those to binary numbers to send the statistician. So this is what my data mining typically looks like. You have the MRN, you have the age, and you see here, most of these are 0s and 1s. And then how do you progress to statistical analysis? So once you have all this data mined, you have your patient cohort, you have the factors you're data mining, you went through the charts and filled in the yeses and nos for all of the factors, and you've looked up all their postoperative outcomes and filled it in. How do we actually get statistical analysis, right? How do we get what we want for the paper? So the main things for retrospective studies that you're evaluating are p-values, and as well as you want to get odds ratios, right? And so typically p-values, they're telling you if something is more statistically significant, and that's how you're finding it. And so odds ratios is when you see something in a paper that says X was 8 times more likely to develop than Y than Z. So you're comparing two cohorts, and it's giving you how much more likely something is to happen, or if something is 8 times more significant. So p-values, the way you ask the statistician to get p-values, you have to ask for bivariate analysis. So you're comparing two different groups for a factor. And so in our previous example, we have Charcot patients with and without diabetes. So with and without diabetes is one of our factor. And then one of the next factor we'd be comparing is age. And so you could get a p-value for age. And then you could compare, for next factor, you compare BMI. And you'd be comparing with and without diabetes to BMI, and you get a p-value. So you individually compare each of these factors one by one, you get p-value for each of them. Whereas multivariate logistic regression actually pulls all of these together. And so this is a way of predicting the differences in outcomes between variables. And so all of the statistically significant factors that you did from your bivariate analysis, so it's all of your significant p-values, you're going to pull into multivariate regression. The one thing that, a caveat to that, is you can't compare preoperative factors and postoperative outcomes in a regression. You have to compare them separately. And so what I always do when I send this to the statistician is I list all the preoperative factors and I list all the postoperative outcomes for him, so he knows he has to run two separate regressions. And so this is an example of something I would send to my statistician along with the data set I showed you before. So I'd send him the Excel data set and has all of it mapped out. And I would say, I'm comparing patients with and without diabetes. And then there's a column there that's for diabetes, so he knows what I'm referencing. And then I'm saying for the following factors, and I list the columns for him so he knows. And then at the end, I say, perform a multivariate logistic regression for things that are statistically significant. And so what do we get back from the statistician, and how do we actually evaluate this? So initially, you want to see what values are statistically significant. And what do these values mean? What is the meaning of the statistical significance? So you want to understand the results of them. And so if the p-value is statistically significant, that shows that there's you're statistically more likely to have this happen, or more likely for this to be increased and decreased. And the regression is showing that you're more likely, it's showing the odds ratio, so you're 8 times more likely for X to happen. Okay, so let's run through the sections of the manuscript. So the sections are title page, abstract, introduction, method, results, discussion, references, and tables of figures. I don't write the manuscript in this order. I find that it's easier to write in a different order. And this is how I just think through it in my head, because if you want to think through it as fluid as possible, you know the title page, you want to really get the concept of the paper. But the best way to follow the order is to go through methods first. Right. So that was really what we were defining before with what is our cohort, how are we evaluating them, what factors are we evaluating. And so you already have that mapped out. And then if you go next to the tables, you're actually filling in what the statistician gave you. So you're filling in all the p-values, you're filling in all of the multivariate regression, you're filling in everything. And then from that, you can produce the results. So you can say what's significant, what positive regressions did you have? And so you can compare, you can put that into your results section. And then once you really have an idea of what the study's showing for significance, then you can write your abstract. And the abstract's where I like to develop a clear idea of what the message of the paper is. So what is our overall conclusion, and what are we thinking about overall is what the meaning of the paper is. And once you have that, you can formulate an introduction. So this is really just highlighting the concepts of the paper and introducing the main ideas. And then the discussion is really where you evaluate why things are significant and how this relates to the previous literature in the space. And then you fill in the references and figures. So this is how I think about writing the paper in this order. And so let's go through each one by one. So the title page, following that example we talked about before, what's a great title? So you want to try to have something as succinct as possible that really encapsulates exactly what you're describing in the paper and with the fewest amount of words, right? So we are looking at Charcot reconstruction outcomes in patients with and without diabetes. That's what we're comparing. And then for the authors, you list them in the order, and the first author is typically typically the author that did the majority of the writing, and the last author is typically the most senior author. And so each of them, you have a number next to them, and then this denotes what their affiliations are. So you have to fill in the affiliations for each author. And so this is example, you just want to know have their title, what department, where they work, and the address. And then you have a section following that's corresponding author. And in that area, you have their name, their title, affiliation, email, phone number, fax. So just a way for the journal or whoever needs to get in touch with them can get in touch with them. It has all their information. And this can either be the primary author, the most senior author. That's just determined between the authors of who wants to be the corresponding author. Excuse me. And then you have this financial disclosure statement. And so you want to disclose if there's any financial disclosures for the authors pertinent to the paper. And if there aren't, you list the author's name and say there's no pertinent disclosures. The next step that I write is the methods. So this helps you define your cohort and your factors. And so things to include in the methods section, you want to have a blurb of how the IRB was approved by the board at your institution. And you want to identify the patients in your study. So how did you find the patients? Was it through CPT codes? Was it through ICD-10 codes? Was it through XYZ surgeons or just one? And what was the time frame? Was it from 2000 to 2020, or is it from 2012 to 2014? So you want to define how you found your patients. So you're letting them know if you need to reproduce this is how you can do it. And then you want to include your inclusion and exclusion criteria in this section. And then for data mining, what factors were evaluated? And so you want to list out what factors you evaluated and help define them, similar to what we talked about before. So you're not just going to say we data mine age. You're going to say we looked at age at time of surgery and clearly define each factor that was evaluated and how they're defined. And then if there's any specific equations or concepts for your paper, you're going to fully define them and how this paper is evaluating it. And then the statistical analysis. So typically my statistician, when he sends me the results, he'll send me a paragraph writing out what specifically he did. And I include this in the methods section. And then within this section, the tables in the results section needs to be written out. So for the tables, you put anything that's statistically significant in, So for the tables of figures, you want to define each that you're going to be evaluating down the road. So for the table section, you're putting in not only just the statistical significance, but you're putting the values. So if you have the age of a patient, you want to put the mean age for the patients with diabetes, the mean age for patients without diabetes, and then if the difference between them is statistically significant, you're going to put that p-value. And so you fill in the data from the statistician in this section. And so each table that appears in the table and figures section are ordered 1, 2, 3, 4, 5, and you need them to appear within your manuscript in that order, and you need to cite them within the manuscript. Typically, the first table is your demographic tables. And so this is just where you're defining your entire cohort. So for our example of patients with and without diabetes, you'd look at all of the patients with and without diabetes, overall demographics. You'd look at the mean age of the entire group, look at the mean BMI of the entire group. So whatever factors in your analysis you're comparing for that are demographics, you'd include for the entire group here. The following tables are typically the bivariate analysis and then secondly, the multivariate regression, right? So if the bivariate analysis gives us the p-values and what's significant, then the regression is from those statistical significant factors, we run a regression. It makes sense to logically go in that order. So here's an example, just a little bit of the demographic table, right? So it's all the patients that both had with and without diabetes, and you're looking at the mean, you're looking at the age, the BMI, and the A1C, and so you want to define all of the demographics for the entire cohort, both the with and without diabetes. Then when you're doing the bivariate analysis, so what I was talking about before with the p-values, you want to define that you're comparing the two groups. And so this is where we're actually breaking down into our tree of comparing patients with and without diabetes. And you're comparing their mean age, and so they do not have a statistically significant difference in their age. BMI, you can see they're relatively close mean BMIs, and there's no statistical significance difference between BMI. And then the regression, this is where you're showing your odds ratio. So from all the factors you compared, there were preoperative factors versus postoperative outcomes that were statistically significant. You run in the regression, and then you want to see which ones of these are significant. And so from that, we know that return to ambulation was 17 times more likely, and you have to have a confidence interval. And this is the statistician will give you these factors. And then so once you have really defined the method sections and you have your tables filled in, I use the tables to then write the results section, right? So the results, you don't want to list out every single results because that would just be repeating what's in the tables. You want to include all of the demographics in that first table. You write those out in a paragraph form. But then from the next tables on, the bivariate analysis and the multivariate regression, you're only writing the significant factors. So for the bivariate analysis, you're just saying if, for example, post-op ambulation was significant, then you put that in, you put the mean, the amount of patients with fully ambulatory status versus non-ambulatory status for each cohort. And then for the regression, the same thing, you're only putting what's significant. After you have the methods and results really clearly mapped out, you understand what your paper findings are, then you want to think through the overall message of the paper. And this is where you're really defining it in your abstract. So your primary and secondary aims of the study, you may only have one aim, so it might just be your aim of your study. We're really defining what you're looking at and what you're comparing. And then you want to say how you're comparing it. So similar to our methods section. So are you performing a bivariate analysis, multivariate regression? And that's where you want to have a statement on the methods. Then the results sections, you want to include what's significant. So you don't want to include all the factors. You won't have enough room for within the abstract. So you're including all the significant factors, similar to your results section. And then what do these results mean? So what is the clinical significance of these statistical significant factors? And that's going to be your conclusion. And so here's an example. I copy pasted the section of the abstract for this. So in our comparison of patients with and without diabetes that we were talking about before, the aim of the study, I defined as the objective of the study is to compare risk-adjusted matched cohort, so that's something separate, of Charcot neuropathy patients who underwent osseous reconstruction with and without diabetes. And then what is our method sentence, right? So bivariate analysis is performed for preoperative factors, location of Charcot breakdown, and postoperative reconstructive outcomes in patients with a minimum of 1 year follow-up, right? So we've defined what statistical analysis we performed, what factors we compared for, and we included some of our inclusion and exclusion criteria that were relevant. And then for the results sentence in the abstract, we want to include just the significant factors, right? So through bivariate analysis, we found preoperative ulcers were statistically more likely in patients with diabetes, et cetera, and you're including the actual p-values to show that they are significant. And then for the regression statement, you're going to say non-diabetic patients were 17 times more likely to return to ambulation. And so you're including all of the positive factors for the regression. And then you need to have a conclusion sentence that really wraps it up. So our results demonstrated that diabetic Charcot patients were more likely to present with preoperative ulcers compared to non-diabetic patients, right? So you're really defining what your study showed and why it's significant. So after you have the abstract done, you really have a clear message of what your paper is trying to present, and then you can highlight the overview of these topics within the introduction paragraph. So the introduction, I typically break it down into around 3 paragraphs. So initially you want to define and go over the literature of the cohort itself. So in the intro paragraph, we talk a little bit about diabetes, we talk a little bit about Charcot, and we talk about patients with and without Charcot within the intro. And then you want to look at if there any other literature pertinent to this. So this is a comparative study, but maybe there was a case series of patients without diabetes with Charcot that was looked at, and you want to put that in. So any literature that's relevant to your study, you want to put the most pertinent in first, of course, and that's how you're going to think about it. And then the last paragraph is, why is this research relevant? And this is where you can conclude with the aim of your study. So you're going to define, why do the readers care about this? And then what is your study actually looking at? And so now that you've kind of introduced the topic, you understand what your paper is saying, you want to really dive into the results, and that's in the discussion. So the discussion, the first paragraph, you're just generally overviewing the topic again and explaining why this concept is important to the reader. And then you're going to go through each significant result within their own paragraph. So in this example, we had patients that had positive preoperative ulcers. Here I have explain why the diabetic patients are more likely to have preoperative ulcers, and you want to support this with literature that you see. You have a paragraph for each factor that's significant. And then after you have that, you're going to have a limitation paragraph. You want to clearly map out for the reader the limitations of your study. So you want to, acknowledge that this is a retrospective study. You want to acknowledge the limitations of there's a small n. Whatever factors are that weaken your paper, you want to clearly define it for the reader. And then you have a conclusion paragraph. And this is where you want to have overall just the concept that you want the reader to take home. And so if you want the reader to take home one message from the paper and have 1 or 2 things that are really you want to hit home, this is when you want to clearly define the conclusion section of the discussion. And then for references, as I go, I typically put in the authors I cite throughout the paper. I don't number them while I go. I'll just put the author's last name as I write the paper. And then even if you're not filling in the references and formatting them as you go, at least put them their name down in the reference section so that later you have a map of what to fill in. And one thing that I learned early on in my residencies, don't number the references until after your all the tendings and all the co-authors have edited the paper. You'll end up having to renumber everything. So I always leave the author's name in, send it to the tendings, and send it to the other co-authors and everybody. And then once I have all the edits, then I number them. And the way you want to number them is as they appear in the paper. So whatever your first citation that you see in the intro, that's going to be number 1. The next one will be number 2. And you want them to match your references. So you want them as they appear in the paper to be numeric, and then you want as they appear in the paper to be within the references themselves to follow that same order. And then for figures, you really just want to have any pertinent clinical or radiographic figures that demonstrate the concepts of your paper. So, in this section, I might have clinical pictures of Charcot or radiographic, how we define Charcot and have a clear radiographic picture that demonstrates it. And if there's any algorithms, decision trees, radiographic measurements that are really key factors of the paper, you have to have a figure for it to show the reader how you're evaluating this and how they can think about it. And then within the paper, you have to have the figures appear within the manuscript as they appear at the end of the figure. So say you have 3 figures, you have to cite them within the paper, figure 1, figure 2, figure 3, and they have to appear in the same order as they do in the paper within your figure section.